Dr. Molina, he is, oops, I'm recording it now. Dr. Molina is our medical director. He's a cardiologist, and he told me not to exaggerate, but he's truly amazing. He is, I'll just say he's a Harvard, Yale, and Stanford trained cardiologist. And I mean, okay, if that's not enough, he's our medical director, and he does so much for so many people. And anybody who knows my own heart journey and that I had an emergency open heart surgery, this was the man who diagnosed me. And if it wasn't for him, I really wouldn't be alive. So I really do mean it, Dr. when I say he's a saint in my eyes and many others. So we're really honored to have him here, and he's our medical director. It's an incredible thing. So thanks for joining us. People will continue to come in, but Dr. Molina, I'm going to spotlight you, and he's going to do something special where instead of doing a PowerPoint, I think he's going to talk to us about heart health for Heart Month, and he's going to have time to answer questions. Is that right?
Yes,
okay.
It's all going to be about that.
All right, so I'm spotlighting Dr. Molina, and get ready to. So I
don't know what spotlighting is, but
I'm spotlighting you, not gaslighting. I'm spotlighting.
Yeah. So welcome. So today, it is true that I am actually the medical director of the South Asian Heart Center, and I'm actually trying to not. I like not to talk to and see myself on the screen because I get distracted about her day. So let's just do a gallery. Great. So my purpose today is to just sort of give you a little bit of overview and a series of definitions of what we mean by heart disease. So as you know, the South Asian Heart Center was created about 16 years ago as a result of the epidemic of heart attacks among young South Asians engineers coming into our El Camino Emergency Department. And the program has evolved, and we have moved not only from the heart disease prevention mode to also a diabetes prevention mode, because we have recognized the connection between the two. And also the South Asian Heart Center is not only designed to manage these conditions among South Asians, is available to anyone and everyone who wants to join. For one part, I'm not South Asian, I'm actually West Indian. So because I was West Indian, and so they asked me to join the South Asian Heart Center. But I'm not from the west of India, I'm from the West Indies down in the Caribbean. So anyhow, to begin, I would like to sort of let you know, what are the different major types of heart condition, and then how they relate to metabolism. Most of the time when individuals are involved in the diabetes prevention program or the Stop D program, the issue here is an issue of digestion. It's an issue of metabolism. It's an issue on how you manage the energy within your physiology and its consequences. And today, without using a PowerPoint, what I'd like to do is to talk you through it. So first, we'll talk about heart disease. And heart disease, when we use the word heart disease, is just a reference to anything that has to do with the cardiovascular system, the heart being the pump, and the vascular being the pipes and the connections that take blood from the heart to the circulation and bring blood back from the circulation, the periphery, back to the heart so that it can circulate through the lungs. When we're talking about coronary artery disease, we're talking about problems that occur in the wall of the coronary arteries. But in a more general term, when we're talking about vascular disease, we're talking about disorders that affect the wall of all the pipes, both pipes that go to the heart, pipes that go to the brain, pipes that go to all your organs, particularly the kidney and the legs. When those pipes are narrowed in the heart, they give you angina. When those pipes are narrowed in the renal artery and the kidney artery, they give you high blood pressure. When they're narrowed to your legs, they give you claudication, meaning they give you pain when you're walking. When they're narrowed in your brain, if they actually close, they give you a little stroke or a big stroke. So they actually, obviously, the pipes carry the blood supply, which is responsible for the oxygen and the nutrients to the tissue. You break the supply and those tissues stop working. You break the supply to a part of the brain that is involved with speech, you cannot talk. Or involved with the use of your right hand, then you cannot use your right hand. Or involved with the certain areas of your heart that gives you a heart attack, and then the heart is damaged and you may not be able to do what you want to do because the pump is not working well. Same is true for any other part of your body. So vascular health is really important. Now, in reference to the South Asian Heart Center, when we're talking about vascular health, we're mainly talking about arteriosclerosis. So the question is, what is arteriosclerosis? Arteriosclerosis is an inflammatory process. It's a process where there is a reaction of many cells involved, and that leads to the production of heat. If inflammation happens in a joint, is swelling and pain and redness. In your vascular tree, you cannot feel any of that, but there is actually the inclusion of the same cells that go into your knuckle that gives you pain. They go there and they have this reaction that leads to the deposition of all different types of other cells, and that can lead to growth and interruption of the flow of blood. If that plaque, we call that a plaque, ruptures, then you have a heart attack. And so you can imagine, you can think of it as coronary arteriosclerosis or any kind of arteriosclerosis as having an acne or a pimple on your face in an arterial wall, and that can heal, or it can progress, rupture, and then give you a clot within the artery, and that will give you a heart attack. Many times what happens is that there is progressive narrowing of an artery as a result of progressive inflammation. Usually that progressive narrowing tends to give you angina or chest discomfort, but rarely ever gives you a heart attack. Most heart attacks occur in narrowings that are not significantly narrowed to give you angina. They're new kind of plaques that are not necessarily obstructing the artery, and then they rupture and give you 100% obstruction. So why is that important? Why am I telling you this? Because sometimes people say, boy, I had an 80% narrowing, and they think, oh my God, 80% is just close to 100 and this gives me a heart attack. But most of the heart attacks do not occur in those blockages. They occur in areas which are minor blockages. Why? Because the 80% narrowed artery tends to be full of fibrosis and full of calcium, and they tend not to rupture and explode like a pimple on your face. So that's really, that's something that I thought it would be important for you to know. But going back, arteriosclerosis, in summary, is an inflammatory process within the wall of the artery. And I told Erica I was not going to show you anything on the screen, but I just can't help myself. So I'm going to sort of show you what I'm talking about here. So you can think about this artery as this little cartoon as an artery, is a pipe, and we're talking about inflammation in the arterial wall. That inflammation then leads to a plaque. You can see that there's really no narrowing in the lumen, or it doesn't affect the blood flow to your heart muscle. So this doesn't give you chest pain. This doesn't give you angina. Now, you also see that there is a thin cap over it, okay? And it is this that tends to give most heart attacks. 60% of heart attacks in men, they actually don't have any pre-existing significant blockage. And that ruptures, and that causes a clot to accumulate. Alternatively, this narrowing over here is the one that gives you angina, but you can see that there is a very, very thick cap that rarely ever ruptures. If this causes a heart attack, the heart attack results from the sludging off of cells on the top of this of the surface here. It does not rupture from here. It's just sludging off of cells covering it, and then as the collagen is exposed, then you can have a clot form here. But we rarely, when we go to the cath lab and take someone who's having a heart attack to open up their artery, we rarely ever find this. We tend to find this. So now, what are the causes of this? Well, we don't know the cause of this, but we know factors associated with this. Now, why am I telling you this? Because we sometimes give the impression that we know what causes heart disease, and in this case, arteriosclerosis. And the fact is that this process of inflammation on the arterial wall, for the most part, can be caused by many things and brought on by many things. The end result is the inflammation in the arterial wall, but that can be the result of just a lot of flow, very high flow. It can be the result of high pressures within the arterial wall. It can be the results of smoking and having nicotine and all those kind of crazy poisons that are in smoke affecting the arterial wall. And it can be the result of cells not metabolizing well, having this metabolism, abnormal digestion of the food that we eat and produce the nutrients that we produce in our liver, kidney, and gut. And they can then lead to inflammatory process in the arterial wall. So in other words, this is the arterial narrowing or blockage is the end possible or potential end result of many factors, some of them genetic, some of them associated with lifestyle, and some of them associated with just luck, that you got an accident, some cells crash together in that area and cause a plaque, cause inflammation, and then you know the rest of the story. Now, that is arteriosclerosis. When we're talking also about heart disease, we're also talking about high blood pressure. And high blood pressure, many times by many people, is considered, well, it's just a number, having a pressure over this number. Now, some people think, oh, hypertension means you're tense. Tension here has nothing to do with your mental tension. It has to do about tension, meaning in the world of physics, tension is pressure. It means high blood pressure. Now, is the problem the pressure? Is that the main problem? And the answer is no. The answer is the problem, the cause of that elevation in the pressure is the underlying problem. So what happens is most of us at a young age, we actually have normal blood pressure. Why? Because the system, the brain, the heart, the kidney, and the adrenal glands are able to maintain a steady pressure. Just like all those systems can maintain a stable temperature and a stable pH and a stable content of oxygen in our bloodstream. There's this regulation, and this regulation maintains a balance. In high blood pressure, the system that maintains the regulation goes out of whack. And then the pressure is reset to another number. So it's a problem of lack of adequate auto-regulation of the pressure. Now, that can be the result of stiffening of the arteries. That can be the result of kidney disease. It can be the result of taking the wrong drugs, the result of drinking too much alcohol, the results of using illegal drugs. It can be the results of sleep deprivation. There are many causes of it, but all those lead to then the absence of adequate auto-regulation of the blood pressure. And why do I say that that's the main underlying problem? I say that because if I give you medicine and I lower the blood pressure can go down. But the consequences of high blood pressure do not go back to baseline. They don't go back to zero. In fact, the risk of heart attack is not changed by adequate, excellent control of the blood pressure in someone who has high blood pressure. That doesn't change. The incidence of stroke goes down, and the incidence of kidney failure goes down, and the incidence of heart failure goes down. But the risk of a heart attack does not go down. Why? Because just lowering the blood pressure does not treat the underlying problem, the underlying vascular and autoregulatory problem that causes high blood pressure. So then, what can you do? Well, you can do a lot. Why? Because we know that if people are overweight or obese, if they lower their weight, the blood pressure goes down. And they actually, that it demonstrates improved autoregulation. We know that if you go down the street, across the street from the hospital, and you learn transcendental meditation, your blood pressure goes down without taking a pill. And what does that mean? That you have improved autoregulation. It means that you start sleeping 7 to 8 hours and you treat your sleep apnea, then your blood pressure will go down. And then you have autoregulation, improved autoregulation. So obviously, looking at lifestyle then leads to improve autoregulation as best as you can achieve autoregulation. Sometimes you can't. And then you normalize your blood pressure. So let me summarize again. So we have talked about two things: arteriosclerosis, an inflammatory process in the arterial wall caused by a large number of causes that can lead to a heart attack or angina, renal hypertension, stroke, and claudication or peripheral arterial disease. We had talked about high blood pressure, which is a condition which is not only a high pressure. The high pressure is what is a demonstration that the system is not well autoregulated. That high pressure has consequences of banging on the walls of the arteries, leading to weakened walls, leading to the possibility of more arteriosclerosis, more inflammation, and also bleeding into the brain, or damaging your kidney, damaging your heart, and damaging your brain circulation, and leading to multi-infarct dementia or dementia. And that's high blood pressure. Then there are other causes of heart disease. There are diseases that are genetic. And this happens in about 1 in 500 to 1 in 200 people in this country, where there is a gene that leads to thickening of the walls of the heart. Therefore, the heart is not able to relax appropriately. The heart is a pump, and that pump does two things. It pumps blood out, but it also has to fill. And that filling is associated with the relaxation of the muscle. If the muscle is thick, then it doesn't relax well. So remember when you were actually blowing into a balloon as a kid, or you're blowing into the balloon of your children and grandchildren, if you have a thin wall balloon, easy. If it is one of the thick wall balloons, you really have to work hard to actually fill that balloon, and you get short of breath. So if you have a thick balloon as a heart that needs to relax and fill, and that requires higher pressures, then when you go up a flight of stairs, you're going to get short of breath. You're going to get short of breath with normal lungs and with normal pipes. It's just that the heart does not relax well. Now, high blood pressure and valvular heart disease can also cause thickening of the heart muscle. Sleep apnea and obesity, which are stressors, can also cause thickening of the heart muscle. So again, there's a genetic component, but there are other things that can lead to thickening of the heart muscle. So now we have talked about three things. We had talked about vascular disease, we had talked about high blood pressure and its problems with autoregulation, and now we have talked about hypertrophic cardiomyopathy. And that hypertrophic cardiomyopathy can be obstructs the flow of blood out of the heart and leads to fainting, for example, in basketball players that sort of die while playing a basketball on national TV, or football players, stuff like that. And or people who have non-obstructive but still have problems with relaxation and arrhythmias. Then we're talking also about other forms of heart disease. So the heart is a muscle, it's a pump, and this pump is controlled by an electrical event. So the heart is an electrical organ, and electrical organs conduct this electricity. And if there is a problem with the conduction of that electricity, then you have what we call an arrhythmia. Either the heart is going too fast, the heart is going too fast, or the heart is going and having irregular heartbeats. And I think that, I think that that's sort of, I'm just telling you about this arrhythmia issue just for completeness sake, and I will not go further into it unless you ask me a question. And then lastly, there is heart disease as a result of chemicals and poisons. So a very common cause of heart disease right now in America is illegal drug use with methamphetamines and cocaine. And that destroys the heart. It causes micro heart attacks, and then you have people showing up in the hospital with heart failure as a result of cocaine and or methamphetamine use. These are not the only poisons that can affect the heart. You can also have excessive alcohol consumption can also affect the heart and lead to congestive heart failure and heart damage. There are also infiltrative and inflammatory conditions. Infiltration of iron in the heart, as you see in hemochromatosis, can lead to heart disease and heart failure. Hemochromatosis is also known as brown diabetes. People get bronze from the iron deposition in the skin. They get heart failure because of iron deposition in the heart. They get liver failure and the risk of liver cancer because of deposition of iron in the liver. And they also get arthritis in these two fingers, in these two joints of these two fingers. And they get hypogonadism because their testes and the gonads are destroyed by iron deposition. There are now genetic tests that we can check to see who is at risk for hemochromatosis. It's not uncommon, but it's not very common. But it's part of the differential diagnosis of someone with heart failure or with cirrhosis. And lastly, valvular problems can cause heart disease, either because of pressure issues on the heart or just too much volume on the heart. So the heart, which pumps about 5 liters per minute of blood, if you have a leaky valve, it can be pumping 15 and 20 liters. And with time, the heart can start failing. There are other conditions where the valves do not open properly, and therefore there is higher pressure required to pump the blood through that smaller hole, and then the heart gets a pressure overload. So I think that so far, I have summarized everything more or less about all of cardiology, except for inflammatory processes. And COVID is one of those, where you have an inflammatory process, a viral illness that can affect the heart muscle and give you viral myocarditis. And we have seen a lot of that with COVID, but then there are also a large number of other viruses that can also afflict the heart and cause a dilated cardiomyopathy as a result of damage to the heart. Other damages that are not very well explained are postpartum cardiomyopathy, where a woman has a baby and all of a sudden she goes into heart failure, and that is called postpartum cardiomyopathy. And I have, in my experience, seen a few of those patients who have been afflicted by that condition. So that's the world overview of cardiology. And if you have any questions, I'll be more than happy to answer them right now. If I don't know the answer, then I will make it up.
Dr. Molina, thank you. That was perfect. And it was 30 minutes and we have 30 minutes for questions. So Rajesh is already writing in the chat. Dr. Molina, you started your talk with mentioning digestion is important to heart health. Could you elaborate further?
That's correct.
How often and what should we look for? Yeah, go ahead.
Yeah, I went on a tangent because we talked about digestion and metabolism, and that this metabolism is also one of the reasons why people can get inflammation in the arterial wall. This metabolism is also the most common cause of cirrhosis in America today due to fatty liver. And this metabolism, abnormal metabolism, is the reason why people get diabetes. So many times, and this is actually, I'm very, very glad for the question that brings me back to the theme uh, and brings me back home to this issue. And that is, when we're talking about problems with diabetes, when we're talking about problems about high blood sugar, the automatic thing is to talk about, oh my God, I ate some candy, or oh my God, I ate some sugar. But that's not the problem. Because when you guys were 12 years old and you had an ice cream cone on a Saturday afternoon, you had normal sugars. The problem was not the sugar in the ice cream cone, is that you had normal capacity to absorb that sugar and digest it and metabolize it into energy and or glycogen to store that energy, so that when you were not eating and you were asleep, that sugar would then, in the form of glycogen, and which is a starch, would then become available to us, because the brain is an obligate glucose metabolizer, and the physiology has to maintain a steady glucose level. It's homeostasis we're talking about. Same with high blood pressure. The physiology maintains a narrow range of blood sugar. Now, when we're talking about digestion, we're extending the process of digestion from eating and absorbing it through our digestive tract. We're taking it to the cellular level. At the cellular level, we call that metabolism. Is how is it that that nutrient gets into the cell wall, and what happens to that nutrient within the cell wall? Does it go into glycogen in the liver, or does it go into energy by the brain, or if it goes into fat in the fat cell? When we're talking about diabetes, we're thinking, oh, sugar, sugar, sugar. But the main problem is that we don't burn well. We don't metabolize well. What does that mean? Most of the time, what it means is that you're not able to get the sugar into the cell. That's what we always think about. Oh, we say, oh, lack of insulin, which is that which drives the sugar into the cell, or insulin resistance. Plenty of insulin, but it's not working. Well, those are two possible. There are two possibilities there. That's true. Those two things can be associated with elevations in the blood sugar. But there are also vascular issues. For example, insignificant adiposity, when you have a big belly, the fat cells within that big belly are not getting adequate blood flow. They're big and they're surrounded by the capillaries. So for all practical purposes, you have decreased blood flow to that fat organ. That leads to ischemia in the fat cell. That leads to inflammation. So obesity is a common cause of an elevated CRP, which is a measurement of inflammation. Obesity is a common cause of cancer. Obesity is a common cause of stroke. Obesity is the most common cause of coronary arteriosclerosis. All of these are inflammatory conditions, and they can be driven by fat cells that are putting out all these kind of signals of inflammation and toxins that then affect the liver and activate the inflammatory cascade. So metabolism is key. Just like your carburetor and what's happening, and your carburetor is key for the function of your engine. If you don't time the fuel into your piston, and you do not have the perfect mixture of air or oxygen and gasoline or fuel in your piston, your engine will not run well. And if it runs dirty. In other words, you are driving to San Francisco burning oil with a smokestack behind you. You may get to San Francisco a few times, but not a lot of times, because you will actually accumulate those deposits. That kind of deposition can be considered something analogous to arteriosclerosis, analogous to cancer and strokes and renal disease and abnormalities in autoregulation.
These are
I
great.
hope I answered that question.
I think so. Rajesh, did that also get to your second part about how often and what should we look for inflammation? Were you asking about testing?
Yeah, and thanks a lot for the analogies. I think I'll remember this for life. Yeah, I just was curious about, what should we be looking for either in our blood reports for as far as inflammation is concerned, and what should those levels be like?
Okay, so that is a very good question because the question is, well, it's a question of testing. It's a question of you develop a software program or you develop hardware and you test it. Is it working right? And we all, look at us at the medical establishment. Okay, let me go and get tested. Am I working right or not? And that actually is a very fair statement and a good statement. And you can actually, the problem though is that you can have perfectly normal numbers and still be in trouble. So why do I say that? Well, cholesterol, for example, is not a very good risk factor for heart disease. In fact, having a good social network is more predictive of cardiovascular health than cholesterol level. For example, I mean, that's an easy one, but it's very well documented. 80% of people with heart attacks have normal cholesterol. 20% of people with heart attacks have low cholesterol. But we know that cholesterol is playing a role. It's just that the role that cholesterol is playing cannot be assessed by just looking at a level. You get that? I'm not saying cholesterol is not involved, but just the level itself is not maybe the best way to assess the risk. So we have ways of measuring inflammation. How do we do that? Well, the most common one is HSCRP. Now, but there are many things. The problem with HSCRP is the following, is that it's a non-specific test. If you actually get any vaccine, you will activate inflammation. If you actually get you have a lot of allergies because it's hay fever season, you will have a lot of inflammation. If you twisted your elbow and now you're limping for a week, you have inflammation. So you cannot differentiate very well as to what is vascular inflammation and what is arthritis, even though we know that people with rheumatoid arthritis, which is an inflammatory condition of the joints, tend to have more heart disease. And there are other inflammatory conditions like thyroid disease. It's an inflammatory condition where you, through thyroiditis, just, Hashimoto thyroiditis, destroy your thyroid, and then that leads to low thyroid, but you go through a process of high thyroid first. So what are the blood tests? Well, you can test for inflammation, the HRCRP, and the sedimentation rate, and ferritin, for example. Now, when you're looking and assessing metabolism, well, you can assess for two things, maybe three things in metabolism. One is the blood sugar. Why? Because that's one of our nutrients. If the levels of sugar are elevated, that tells you two things. You are not regulating the sugar metabolism well. What can that be? You're either producing too much sugar by the liver, and it's a problem of production. We call that gluconeogenesis. That production, you're doing fasting, so you're doing your blood test soon after waking up. So when you're sleeping in the early morning hours, you have very high levels of stress hormones. Those stress hormones push the blood, put the blood sugar up. And what you're assessing in that fasting blood sugar is the product of gluconeogenesis by the liver, the production of new sugar that is going out of whack, that has overextended what it should do because of the problem of autoregulation. In others, you're not seeing a problem of too much sugar production, you're having a problem of sugar disposal, meaning having the sugar enter the cell. Now, why is it that the sugar cannot enter the cell? Maybe because the cell is full. And that's what happens with obesity. You have a full battery, and sugar means fuel, and fat is that stored fuel, and you have a big fat cell. So it's going to be more difficult to get more fuel into that fat cell. We blame insulin resistance, But it's not the lack of insulin, it's that that cell is full. And then there are other factors, there can be autoimmune problems and antibodies and this and that, but that's really the majority of the case. Now, what then? You look at glucose. So what is another thing that we need for fuel? Well, triglycerides are fats, or most of our body runs on fat. It does not run on sugar. Our brain runs on sugar, or cells in the bloodstream run on sugar. Everything else runs on fat. Why? Because the system prefers premium gasoline versus regular. Sugar gives you 4 calories per gram. Fat gives you 9 calories per gram. So the efficiency is always driven in physiology. We always want to be efficient. Therefore, fat is the preferred fuel for the heart muscle, your skeletal muscle, and everything else other than your brain. The brain cannot use fat. So if you have high triglycerides, then you know that there's also another problem with metabolism, sugar and triglycerides. And then I said a third thing. Well, you can look at the ratio of triglycerides and HDL cholesterol. That is a ratio that identifies some insulin resistance. And in a man, if the ratio is greater than 3.5 between triglycerides and HDL in milligrams per deciliter, that suggests insulin resistance. And in a woman, 2.5. If the ratio is greater than 2.5, also suggests insulin resistance. So how do you do to get rid of it? Well, you lower your carbohydrate intake to drive the insulin less, to force your physiology to use your stored glucose in the form of glycogen in the liver and in your kidney and muscle. And you exercise. What is the effect of exercise? Well, the machine starts running, the muscles start moving, and that requires energy. That energy requirement opens up the cell for sugar and fat to go in without even in the absence of insulin. That's one thing. And the other is that exercises increases blood flow, and that blood flow increases to the fat cell, which is relatively deficient in blood flow. You are bringing, you touch your belly, that's a little cold. I mean, that's where your fat is. There's no muscle to generate heat. But what you're doing is you're forcing, you're heating up your system, and that's forcing blood flow to your fat cells so that they become part of your network of energy. So the way I like to see it is having like a battery full of energy, but it's offline. So when you need that energy, instead of going to that fat cell, you go to the refrigerator. So what you want to do is to be able to get that fat cell, that battery back online so that you don't have to raid the refrigerator or your pantry. Did I answer the question?
Yes, thank you very much, Dr.
You're welcome.
Molina.
Yeah, and that might have also answered Jaya's question, and then I'll get to you, Adwait, about ways to improve and correct metabolism, maybe meds and what
So
you think.
it actually, it's multifactorial. First of all, activity depends on rest. So you need to get adequate rest. And sleep deprivation is associated with this metabolism. You start seeing insulin resistance after one night of sleep deprivation. So rest is very important. Sleep is very important. Meditation is very important. Second, physical activity, moving is very important. You need to get the engine to run. And I'm just getting the actin and the myosin walking on each other. That's the muscular movement. And then, which is sort of interesting because you would expect, you need to eat the right food. Eating the right food is very important, but you need to rest and you need to exercise because that is what primes the system to receive the good fuel. Now, if you're eating fast food for breakfast, lunch, and dinner at McDonald's, you're in trouble because you're eating poison. You cannot eat poison, but you need to sort of, eat well-prepared, freshly prepared, fresh food, rich in vegetables. So it's not what you eat, it's what you don't eat that is most important. But the quality of the food is also important.
Excellent. Dwight has a question that he wants to ask.
Yeah. Firstly, thanks again for making yourself available to answer our questions. So I appreciate it.
My pleasure.
Yeah. Next, I had a question on blood pressure and artery health. Earlier, you showed a diagram about how when the arteries get clogged, it increases blood pressure. My question is that if your blood pressure is, let's say your blood pressure is regulated without medication, does that mean your arteries are okay?
No.
Or, okay. And if
It
not,
just means that your autoregulatory process is working well. Now, there is, as we get older, the aorta, which is the main artery coming out of the heart, loses its compliance. So when you were 20 years old and you put out, 150 cc's of blood very quickly, that aorta expands and is compliant. And you know that pressure has to do with radius, R to the fourth, according to Apostol's law. So if you expand the radius, the blood pressure is not going to up very much, because you go from here to here, and therefore there's increased compliance, the pressure doesn't go up. Now, with time, some individuals will lose that compliance and the systolic blood pressure will start going up. The normal auto-regulated individual, as she approaches the age of 80 or 85 and is finding herself with less compliant arteries, it lowers the diastolic blood pressure. The normal auto-regulation is because there's still a desire to auto-regulate, it lowers the diastolic. So you have a wider pulse pressure. This you cannot do very much about because the compliance is gone. It's result of loss of the elastic lamina within the aorta. That can happen to some individuals faster than others, depending on possibly the genetic material, genetic underpinning, and then other stressors. And if you don't have significant renal artery stenosis, then it doesn't elevate your blood pressure. But one thing is really important, that the presence of coronary calcification on a heart scan, even if your blood pressure is normal today, is predictor of hypertension in the future. Because you're dealing with sick blood vessels and the lack of compliance and the lack of autoregulation. You're dealing with this generalized problem. It's just not only in the heart. Hopefully that answers your question, but you cannot conclude that you have a healthy vasculature if your blood pressure is normal. Now, if you're 70 years old and your blood pressure is 100/60, I could say that you're in pretty good shape, and that's outstanding. I mean, that probably suggests that you don't have a lot of significant arteriosclerosis, but I cannot guarantee it.
Excellent. I have a direct message from Mon about what the relationship with diabetes and heart problems is.
Yeah, that's actually a very good question, and that is, diabetes is one of the most, if not the most important risk factor for cardiovascular disease. So someone with diabetes is someone who's been diagnosed with diabetes is considered to have coronary artery disease, meaning if you have had a heart attack, you have another risk of having a heart attack because you already have the disease. If you have been diagnosed with diabetes, you have that same risk as someone who has had a previous heart attack. Now, that's a very strong statement. That's why the presence of diabetes is, the medications are the same that you give someone with coronary artery disease, because you want to prevent a heart attack in someone who's at high risk. Now, most recently, there have been some papers saying, maybe it's not that bad. But that is presently the correct assessment of diabetes as a risk factor for heart attack.
I don't know if you moved on to the next question, but my internet went out, but thank you very much for your answer.
Yeah, I'm waiting for you to ask me questions. I'm not reading the
Okay.
questions
Yeah.
in the meeting chat.
Hello.
So it's
yeah,
up to
earlier you
Erica
said that
and,
there's,
Who's that
yeah, can you hear
talking?
me?
and Lila.
Hello, this is Young.
I think, who is that?
This is Young.
So
Yeah.
there's a question about aerobic and anaerobic heart rates.
Yeah, that was
So
from
you burn
Rajiv.
fat when you're aerobic. You don't burn fat when you're anaerobic. When you're anaerobic, you're just burning sugar. Now, the question is, what leads to increased fitness? Sprint test, exercising, high intensity exercise where you go anaerobic, or aerobic exercise. Well, high intensity because you're pushing yourself, not because you're aerobic or anaerobic, but because you're pushing yourself. Number one. Number two, an anaerobic signal to the heart, to the muscle, to skeletal muscle, is a signal for the muscle to grow. So if you want to actually get stronger skeletal muscle, what you want to do is not lift heavy weights, is to lift lighter weights many times until you get a burn, because that burn will stimulate the muscle growth. That's why sprint runners tend to be extremely muscular, and that's why marathon runners tend to be extremely lanky.
Can you say it again? So you should you want to grow muscle, you do the lightweight more many repetitions.
Until you're able to get burned. So you don't get a muscle burn when you're lifting heavy weights for 1 or 2 reps. You just get, oh my God, can I do it? But you're not, you're not growing the muscle then. You're not getting the muscle burn. So you get more muscular, not by lifting more weights, but by doing more reps, and to the point where you get burn, you get a burn on the muscle. And the example, the image is the sprint runner versus the marathon runner.
Yeah, the marathon runner, I would assume the repetition they have done is more, right? Because
I'm sorry, can you speak a little louder or get closer to your microphone? I cannot hear you.
Okay, no, can you hear me okay?
I can hear you better now.
Okay, cool. So for marathon runner, you would think that repetition is much more because they run like 40 some kilometers, right? If they run for a couple hours,
Yes.
so they repeat more. But then would they grow more muscle according to your theory?
No, they have more mitochondria in the muscle, and they have improved vasculature and delivery of oxygen to the muscle. But you see in the pictures.
Right. Okay. And also earlier you mentioned that like insulin resistance, the ratio is cross-check HDL.
It's the triglyceride over the HDL.
Yeah, okay. What number? What's the optimal number?
For a man, less than 3.5. For a woman, less than 2.5.
Less than 3.5. Okay.
Yeah.
All right, it's been a really great talk. We're coming into the last few minutes. Any burning questions or thoughts? Well, we have Dr. Molina here about heart health.
Let's see.
Lisa, go ahead.
Yeah, you're talking about obesity being a factor, but the losing large amount of weight, getting from obese to normal weight, is usually not considered to be something you can do sustainably. I mean, we're aiming for a 7% weight loss, but not like 30% weight loss or something like that. How does that play into all of this?
Because a 7% drop in weight has been associated with a significant drop in the incidence of diabetes over a 3-year period of 58%. but obviously there's a linear relationship. There's no linear relationship between your cholesterol and heart disease and stroke, but there's a linear relationship between your BMI and heart disease, stroke, and diabetes and cancer. So now you're actually making a very good point, and that is, it is not easy to lose weight. It is difficult because your brain has set up a weight for you. And that part of the brain that controls your weight is very accurate in controlling your weight. That's why you don't have to buy a new shirt or a new pant every 2 weeks. You are very steady for the most part. And you're eating different things and being different, having different levels of activity because your brain can do the math very well. So that part of your brain is a great mathematician, but does not understand English. You cannot say, please, let's cut down my appetite. It will just, then it's your it's your cortex up on top that is trying for you to lose weight, because this one understands English and understands what you need to do. But it doesn't communicate very well with the satiety center. And that's why we have all these supports. We are trying to look at all these tricks, and that's why we're, looking at different, we all get enamored with a gadget here and there. I mean, we're looking for other ways of getting that part of your brain to give you a break and let you go down to gain the health benefit and the well-being of a lower weight. But that's what, so that's really, you have, you hit a very important point. It is not easy to lose weight, and it's not easy to lose weight because it's not because we don't have willpower, and it is not because we love food too much. It does play a role that we are surrounded by weapons of mass expansion. Clearly, that plays a role in the obesity epidemic in America. But actually, what happens is that we have reset our satiety center. We actually have changed. And you can sort of see how our weight has changed from at the beginning of the 20th century, where the typical American slept 9 hours and there was no TV and no internet, to 1975, when there was Johnny Carson and the typical American slept less than 7 hours, and there was a big uptick in the weight. And now that we have the internet, Netflix, and et al., and now we have, significant epidemic of obesity and sleep deprivation, where the typical person sleeps less than 7 hours. And that's a major, problem. I mean, and this is a major problem in this, particularly in this nation, but around, around the world.
Dr. Molina?
Yeah.
I have Rose on the phone, so she doesn't have a voice, but her question has to do with hearing you say to reduce carbs, but what about fruits and vegetables that have carbohydrates?
What is the question about release carbs?
She heard you say reduce carbohydrates.
Oh,
but she was saying,
so
fruits
that
and
actually
vegetables.
reduce carbohydrates. So what I was saying is that diabetes is not a problem of just eating too many carbohydrates. It's a problem of metabolizing those carbohydrates. And I use the general term digestion because I think people really get that better. They understand that better than just metabolism that just happens so far, far away. But everybody, all of us have learned the word indigestion. So it's the indigestion at the cellular level of the nutrients. So fruits have a lot of sugar. They have a lot of fructose. And it's just a matter of how much you eat. Now, fruits also have a lot of antioxidants and have a lot of benefit. So there is fructose, there is sugar. We are supposed to consume about 400 calories of sugar per day to maintain our brain happy. So if we don't consume the 400 calories of sugar per day, we're going to digest our muscle for that sugar. And you don't want to digest your muscle for that sugar. So sugar is not the enemy. but you don't want to have 2,000 calories in sugar from drinking Coca-Cola and Pepsi-Cola and all that, and going to McDonald's and eating a hamburger with sweet bread, because the bread is sweet, that they serve you a bun. It's not regular bread, it's added sugar to that bread because Americans love sweet. So, so how much fruit? Fruit consumption has been associated with increased risk of diabetes. So what is the dose? But the dose is 1/5 of fruit per day. Now, there may be a little day that you may have a little more, because it will go bad, but it's really 1/5 per day. And I would favor blueberries. Why? Because 3 servings or a cup and a half per week of blueberries is associated with about a 28% reduction in diabetes. Not because of the sugar of the blueberries, but because the other stuff that comes along with the blueberries. So the more fiber you have in your diet, the lower the risk of diabetes. That in the form of fruit or in the form of grain or in the form of vegetable.
Thank you. And coming to the end, to the top of the hour, and maybe the last question by Ajay is about metabolic syndrome. What are the recommendations to either control or reverse metabolic syndrome?
So that's a really good question. And
That
we
might
actually
need explanation to what it is too.
So metabolic syndrome is a condition that was described by Jerry Reven, who was one of my mentors at Stanford and with whom we have published a few papers at the South Asian Heart Center. And he coined the word metabolic syndrome. He's now recently deceased, but a fantastic man, a great teacher, good scientist. I mean, he was always, coming up with ideas. So metabolic syndrome was defined as the consequences of obesity by Jerry Reven. And the syndrome is defined by being overweight or obese, a BMI, or having a significant abdominal waist in a man or a woman, having high blood sugar, high blood pressure, low good cholesterol, low HDL, and high triglycerides. That combination, which is a combination that demonstrates poor metabolism, poor autoregulation of the sugar, poor autoregulation of the blood pressure, and poor autoregulation of the weight, is associated with a significantly increased risk of heart disease, diabetes, and heart attack, and cancer, and stroke, and anything bad that can happen to us. So that's metabolic syndrome. 3 out of the 5 make that diagnosis.
And
in some circles, they have, there are 3 of the 5, it doesn't, but Jerry said, well, it has to be driven by obesity. I mean, it's an issue of, driven by the weight.
and did you have anything different to add aside from what we've said for?
No, I mean, how you treat it?
Yeah.
You exercise,
Reversing.
you lose weight, you sleep. I mean, you do meds.
Meds.
Yeah.
Well, we came to 6 o'clock. It's been a great honor and pleasure.
And by the way,
Yeah.
transcendental meditation and a study published from Cedars-Sinai, published in the Archives of Internal Medicine, decreases insulin resistance and metabolic syndrome.
That's incredible. Dr. Molina
Anything
has
else?
been meditating for 50 years. Yes?
53, yeah.
53 years. Twice a day, every day for
Yeah.
53 years. All right, we're getting a lot of thank yous. I'm not sure if there's any last questions, but it was just such an honor to have you here. Just a little wrap up. Some of you may need to go, but we have some combined classes here. If you're in my Tuesday class, our next class is March 7th, and we'll be doing that for 2 Tuesdays. And those of you in my monthly Tuesday, it's next month on March 21st. It's our graduating class. And Leela is next week on Tuesday also, right? Or Wednesday.
Yes, Tuesday.
Right. Any other questions for Dr. Molina? I'm just saying awesome session. Thank you so much. Interesting, enlightening, always a joy. Thank you. Informative. Thank you. We're so appreciative that you're here,
Bye.
Dr. Molina.